Welcome to another episode from the Veterinary Research Channel. Today, we're diving deep into a critical area of veterinary medicine, seizure emergencies in our canine and feline companions. Drawing from the latest consensus statement by the American College of Veterinary Internal Medicine, we'll explore the recognition, classification, and management of status epilepticus and cluster seizures. This episode aims to provide you with up-to-date information so that you can best respond to these challenging neurological disorders. Our story begins with understanding just how common seizure disorders are, representing frequent neurological emergencies. Status epilepticus, a particularly severe form, carries a significant mortality rate, ranging from 25.3% to 38.5%. Delayed treatment can lead to irreversible brain damage and systemic complications, so rapid intervention is key. Seizures can become self-sustaining and resistant to standard anti-seizure medications, which means that veterinary clinicians need to respond quickly and efficiently. Traditionally, a seizure lasting less than 5 minutes was considered brief, while anything between 5 and 30 minutes was deemed prolonged. However, the International League Against Epilepsy and the American Epilepsy Society define status epilepticus as continuous seizure activity, or a series of seizures without full recovery of consciousness in between, lasting longer than 30 minutes. But here's where it gets interesting. Because most seizures are brief, intervention should occur much earlier. The International Veterinary Epilepsy Task Force defines status epilepticus as seizures lasting at least 5 minutes or 2 or more seizures without full recovery in between. This more immediate definition emphasizes the need for prompt action to prevent long-term consequences. Now, let's talk about cluster seizures. These are defined as 2 or more self-limiting seizures within a 24-hour period. High-frequency cluster seizures carry risks similar to status epilepticus, including neuronal damage and the potential to progress to status epilepticus. Without medication, these seizures are unlikely to stop on their own. Seizures can manifest differently, with varying levels of motor activity and consciousness impairment. In veterinary medicine, generalized tonic-clonic seizures are the most commonly reported form of status epilepticus. However, diagnosing convulsive and non-convulsive status epilepticus can be tricky, partly due to the limited use of electroencephalography, or EEG, in veterinary practice. Non-convulsive status epilepticus should be considered in animals with prolonged altered consciousness, especially after convulsive seizures have been managed or after general anesthesia is withdrawn. Ideally, EEG should be used in neurological cases with impaired consciousness to assess non-convulsive status epilepticus before treatment, but this might not always be feasible. Now, let's move on to what happens in the brain during status epilepticus. The consensus statement divides it into 4 stages. Stage 1, impending. This involves neurotransmitter release and ion channel imbalances. Stage 2, established. Here, there's a decrease in certain receptors in the brain, along with an upregulation of other receptors. Stage 3, refractory. At this point, neuropeptides are released and there may be changes in drug transporters. Stage 4, superrefractory. This stage involves alterations in gene expression. These stages illustrate how status epilepticus can become progressively drug-resistant. So, how do specialists come to an agreement on managing these complex conditions? A consensus panel was formed, consisting of 5 experts in veterinary internal medicine and urology. The panel conducted a thorough review of available literature, identified gaps in knowledge, and made recommendations based on current evidence and clinical experience. They also reviewed experimental laboratory animal studies, basic research, and human medicine guidelines to support their statements. The panel followed a rigorous methodology: literature search. They used 3 scientific databases, including publications from major veterinary neurology conferences. Screening. The panel included peer-reviewed studies of dogs and cats, clinical and pharmacokinetic studies, and research evaluating anti-seizure medications for emergency seizures. Quality of evidence assessment. The panel assessed studies based on factors like study design, group sizes, and methods for evaluating treatment outcomes. Treatment outcomes assessment. They analyzed each study's treatment outcome, looking at factors like seizure termination and the safety profile of interventions. Drafting the recommendations. The panel used a level of evidence scale to categorize each intervention, ranging from high to absent. The level of evidence was categorized using the following scale. Level 1, high level of evidence from at least 2 high-quality clinical studies. Level 2, moderate level of evidence from at least 2 moderate-quality clinical studies, or 1 high-quality study. Level 3, Low level of evidence from one low-quality study or pharmacokinetic studies. Level 4, conflicting evidence from multiple clinical studies. Level V, absence of evidence. Based on the level of evidence, the panel assigned an ACVIM recommendation scale to each intervention. A, high recommendation, most likely effective and safe. B, moderate recommendation, possibly effective and safe. C, low recommendation, possibly an inadequately effective and safe treatment. D, not supported for use, ineffective or unsafe. E, recommendation withheld, limited to absent evidence, clinical experience, or both. The panel reviewed thousands of citations. After exclusions, they selected 38 clinical studies on status epilepticus and 12 clinical studies on cluster seizures, along with 37 pharmacokinetic studies, for review. The overall quality of evidence varied, with high-quality studies making up 17% of status epilepticus research and 25% of cluster seizures research in dogs. In cats, 20% of status epilepticus studies were high quality. Now, let's get into specific guidelines and recommendations for treating status epilepticus. While medication is crucial, a comprehensive approach includes supportive treatment and identifying the underlying cause. For first-line treatment, the consensus is that intravenous or 4 and intranasal, or IN, routes of administration are the most effective and safest for benzodiazepines. Out of hospital, the recommendations include intranasal midazolam for dogs, recommendation A, and cats, recommendation E. Rectal diazepam for dogs, recommendation C, and cats, recommendation E. Intramuscular midazolam for dogs, recommendation B, and cats, recommendation E, if caregivers are medically trained. In hospital, the recommendations include intravenous midazolam for dogs, recommendation A, and cats, recommendation B. Intravenous diazepam for dogs, recommendation A, and cats, recommendation B. Intranasal midazolam for dogs, recommendation A, and cats, recommendation E, especially when 4 access isn't immediately possible. Intramuscular midazolam for dogs, recommendation B, and cats, recommendation E. Recent evidence suggests that intranasal administration may be as effective or even superior to intravenous administration, especially when considering the time it takes to place in catheter in a seizing animal. While rectal diazepam has been a common choice for out-of-hospital treatment, intranasal midazolam is likely more potent and faster-acting. Intramuscular midazolam is a viable alternative when 4 or IN routes aren't available. Both midazolam and diazepam are potent and safe, but midazolam may be more so. Studies have shown midazolam to be more effective in suppressing seizures and has demonstrated a higher rate of seizure termination. However, midazolam has a shorter half-life than diazepam, which may require a continuous rate infusion to maintain its effects. If initial boluses of benzodiazepines are ineffective, the guidelines suggest administering another bolus, followed by a continuous rate infusion, or CRI, of a benzodiazepine. In dogs, midazolam or diazepam can be used, while in cats, midazolam is preferred due to safety concerns with diazepam. The panel considered a benzodiazepine effective if seizure activity terminated within 5 minutes and didn't relapse for at least 10 minutes. They advise a 2-minute interval between boluses to avoid delays in treatment. If seizures recur after 2 benzodiazepine boluses, a 3rd bolus immediately followed by a benzodiazepine for CRI is recommended. Diazepam has limitations, including the fact that it can accumulate in the central nervous system and cause severe issues. Diazepam can't be stored in plastic syringes or infusion lines, and the infusion line should be wrapped in a dense material because diazepam is light-sensitive. Also, it's diluted in propylene glycol, which can cause phlebitis and hypotension. These issues are less common with midazolam. If first-line treatments fail, second-line options include levetiracetam and phenobarbital. Intravenous levetiracetam is preferred, but if 4 access isn't possible, intramuscular or rectal administration can be considered. Intravenous phenobarbital should also be initiated. Clinicians should consider starting these second-line treatments earlier in conjunction with benzodiazepines. This simultaneous polytherapy approach may increase the probability of terminating seizure emergencies earlier and establishing a more effective long-term management plan. When first and second-line treatments are not enough, third-line treatment involves anesthetic medications. A 4-step approach can be followed. First step, initiate ketamine for bolus, followed by CRI in dogs and cats. Dexmedetomidine for bolus and CRI should be initiated in dogs and cats if seizures persist after ketamine administration. Second step, initiate propofol for bolus, followed by CRI. In dogs if seizures persist after ketamine and dexmedetomidine for CRIs. Caution should be taken with repeated boluses of propofol and particularly with CRI in cats because of safety concerns. Third step, anesthetic barbiturates for bolus and CRI can be initiated in dogs and cats if seizures persist after propofol for CRI. Fourth step, inhalational anesthesia should be initiated in dogs and cats if seizures persist after the previous interventions. Ketamine, dexmedetomidine, propofol, barbiturates, and inhalant anesthetics are all recommended agents for refractory status epilepticus. There's no comparative evidence for the superiority of one anesthetic over another. Dexmedetomidine acts by decreasing excitatory neurotransmitters. It also has neuroprotective properties. Ketamine increases blood pressure, which may counteract the hypotensive effects of other anesthetics. Propofol acts on certain receptors in the brain. Barbiturates also have a neuroprotective effect. Inhalant anesthetics decrease neuronal membrane excitability and neurotransmitter release. In cases where first, second, and third-line treatments fail, other pharmacological interventions can be considered, including intravenous magnesium and allopregnanolone. If these also fail, non-pharmacological interventions like neurostimulation can be explored. Animals that are refractory to all lines of treatment have progressed to the super-refractory stage. Magnesium may inhibit certain receptors and increase cerebral blood flow. Allopregnanolone may act on certain receptors in the brain. Hypothermia decreases excitatory neurotransmitters and cerebral metabolic rate. Immunomodulatory treatments, like corticosteroids, may also help. Neurostimulation has shown promise in human medicine. So, when should anti-seizure medications be stopped? If no further seizure activity occurs for 24 to 48 hours after the last intervention, then no further anesthetic medication is needed. All current anesthetic treatments should be continued at dosages that achieved seizure cessation for 24 to 48 hours after resolution of seizures. Electroencephalography combined with clinical confirmation of seizure cessation is preferred compared to only clinical confirmation, especially in the case of nonconvulsive status epilepticus. During anesthetic tapering, it's advised that animals be seizure-free for 24 to 48 hours. Progressive sequential discontinuation of anesthetic drugs should be performed ideally over a 24 to 48-hour period. Simultaneous tapering of more than one anesthetic is not recommended. Inhalation anesthetics can be discontinued first, followed by propofol or pentobarbital CRI, then ketamine CRI, and lastly dexmedetomidine and benzodiazepine CRI. Non-anesthetic anti-seizure medications should be administered until the animal is discharged from the hospital or over the long term, using constant doses. Once status epilepticus has been successfully controlled, highly sedating anesthetic medications should be discontinued to avoid severe adverse effects and complications. The discontinuation strategy should be diligent enough to prevent relapse of status epilepticus. Now, let's shift our focus to cluster seizures. Short-term treatment includes short-acting and longer-acting interventions. A three-step short-term plan can be followed. First step out of hospital settings include short-acting medications such as intranasal midazolam in dogs and cats, or rectal diazepam in dogs and cats. Longer-acting medications such as levetiracetam administered orally in dogs and cats. In hospital settings include short-acting medications such as intravenous midazolam in dogs and cats, intravenous diazepam in dogs, intranasal midazolam in dogs and cats, or intramuscular midazolam in dogs and cats. If there is a relapse of seizures after the last benzodiazepine boluses, then another bolus should be administered followed immediately by midazolam for CRI in dogs and cats. Alternatively, diazepam for bolus and CRI can be administered in dogs only if midazolam is not available. Longer-acting medications such as levetiracetam pulse treatment administered intravenously in dogs and cats. Second step, if the cluster seizures persist despite levetiracetam and short-acting benzodiazepine combination treatment, then longer-acting benzodiazepines can be administered orally as a pulse treatment every 8 to 12 hours in dogs and cats. Or, additional dosages of anti-seizure medications used for the long-term management of epilepsy, such as phenobarbital, can be administered. Third step, if cluster seizures still persist after the aforementioned polytherapy, then further interventions, as indicated for status epilepticus cases, should be initiated. When cluster seizures occur, a short-term treatment plan can be initiated during or immediately after the first seizure. Pulse treatment has been recommended instead of long-term continuous treatment because it might prevent the development of tolerance associated with the drug's chronic use. For the in-hospital setting, intravenous midazolam, in particular, should be used in both dogs and cats as the first option. Intravenous diazepam may be used in dogs only if midazolam is not an option. In cats, it is not recommended because of safety concerns. And 4-benzodiazepine CRI, in particular midazolam, can be initiated if a relapse of seizures occurs, with the aim of achieving a steady and constant anti-seizure effect. Blood sampling for assessing serum concentrations of the long-term anti-seizure medications should be performed and dosage adjustments made accordingly. In conclusion, seizure emergencies are challenging, with complex pathophysiology and a rapidly progressive drug-resistant and self-sustaining character. Successful management includes a stage-based treatment approach, addressing the obstacles and prevention of the refractory stages, and management of the complications and underlying causes related to the seizure emergencies. Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.